one sa start. Okay, I really want to include this in the exam. So this is chapter 27, drugs for hyperlipidemia. I really want to finish kasi cardiovascular disorders and at the same time yung drugs for metabolic disorders kasi diabetes is also a metabolic disorder and at the same time yung obesity, mataas na cholesterol level, metabolic disorders kasi yan sila sa body. Hindi natin na-metabolize masyado yung sugar natin and yung mga cholesterol natin kaya nagkakaroon ng condition. So take note ha, hyperlipidemia meaning you will have increased lipid levels in the body. When I talk about lipids, I'm talking about not just fats and oils but also cholesterol. Especially cholesterol kasi it has the ability to be deposited in the blood vessels. We call that atherosclerotic plaque and that will impede blood flow. Okay? Now sa cholesterol natin, we have different types of cholesterols. We have the so-called lipoproteins. Lipoproteins kasi, ano siya, combination siya of lipids and proteins. So marami yan sila, LDL, IDL, VLDL, and LPA. All of these are bad cholesterols. Actually, the low LDL talaga yung tinatawag natin na bad cholesterols. But other lipoproteins can also increase cholesterol level in the body and meron siyang mga, syempre, sequelae. When I say sequelae, clinical sequelae, yung corresponding disease na iko-cause niya. And yan yung atherosclerosis. And for some cases, pwedeng acute pancreatitis kung marami na masyadong cholesterol. Okay, so yan ha, magde-deposit yan siya dyan. So sa mga persons with increased cholesterol in the body, ito yung ginagamit natin ng mga drugs. Magdiretso na ako ha kasi again, nandoon sa video. I hope tinignan nyo siya sa inyong free time, yung video sa first part of this. Okay, introduction kasi yun siya. I really want to focus sa drugs today. Sana yun. Okay, sobra na. Okay, ito kasi yung focus natin this morning. Pag mataas na ang cholesterol or mataas na ang fats or oils in the body, ito na yung mga drugs na binibigay natin to, number one, to prevent atherosclerosis, and then yung other pa na sequelae ng atherosclerosis, di ba? Pag may atherosclerosis, pwedeng ang patient may experience angina, arrhythmia, heart failure. Yun yung piniprevent natin. Kaya kapag may cardiac problem yung patient, most of the time, nakikita nyo din ito sa reseta niya aside sa drugs for the heart like digoxin and yung mga losartan and mga diuretic, makikita niyo din ito sila. Again, to bring down or to lower the cholesterol level. Most of the time, it will be the cholesterol. Pero meron din naman tayong drugs kapag ang problema ng patient is triglycerides. Okay, so let's start with competitive inhibitors of HMG-CoA reductase. HMG-CoA means 3-hydroxyl 3-methylglutaryl coenzyme A reductase. So from the word itself, reductase, class enzyme ito. And actually, itong part na ito sa pathway, ang rate limiting step, balikan lang natin konti para maintindihan nyo siya if you are not able to really watch the video, no? Kasi na busy, no? Ito yung cholesterol biosynthesis natin sa body. Cholesterol synthesis in the body happens at night. So kaya tama yung diet class na before 6 p.m., huwag ka nang kumain. Kasi pag kumain ka pa, marami kang source na marami kang raw material for you to have cholesterol. Kasi yung raw material talaga natin pag mag-cholesterol synthesis tayo is the acetyl coenzyme A. Remember, before tayo nag-end sa ating discussion sa diabetes, sabi ko, sa glycolysis, si glucose magiging pyruvate. Tapos, pagkatapos ng pyruvate, i-convert siya sa acetyl coenzyme A. Tapos mag-Krebs cycle siya. Pero actually, pag wala ka namang ginawa, hindi mo kailangan ng ATP, ng energy, instead na si acetyl coenzyme A mag-Krebs cycle, dito siya papasok sa cholesterol biosynthesis. So, aside from glucose na magiging acetyl coenzyme A, yung kinain mo din na fats and oily foods or cholesterol-rich foods, dito rin yung ending nila. Kasi when they are metabolized in the body, all of them will become acetyl coenzyme A. So pag marami kang acetyl coenzyme A, ang ending mo nun, marami ka ding mapoproduce na cholesterol. Okay? Kasi again, carbs man yung kinain mo, fatty foods man yan siya, cholesterol-rich foods, ang ending nila sa body, acetyl coenzyme A. So kung marami kang ginagawa, syempre Krebs cycle yon, kasi kailangan mo energy. Pero pag wala kang ginawa, dito yun papasok, cholesterol. Pero again, cholesterol biosynthesis happens at night. So pag daghan kay kagikaon sa gabi class, mauna gyud na siya. Ha? So, ito yung pathway. Acetyl coenzyme A will become HMG-CoA. Again, that's 3-hydroxyl, 3-methyl glutaryl coenzyme A. And then, kailangan natin ng enzyme na ito para maging mevalonate. So, ito yung class, rate limiting step. Okay? Kailangan natin ito para ma-produce talaga, mako-commit na kasi talaga siya na maging cholesterol pag si HMG-CoA naging mevalonate na. Tapos, si mevalonate ay ma-phosphorylized. So, we have mevalonate PP, isopentenyl PP, geranyl PP, farnesyl, and squalene. Tapos, from squalene, magiging cholesterol na siya. So, okay lang yung mga ibang proteins dyan kung hindi niyo siya ma-familiarize. Pero dito kasi tayo naka-concentrate na maging cholesterol talaga siya. Now, yung drugs natin, para ma-inhibit yung pagkabuo ng maraming cholesterol, especially the statins, ito yung mechanism of action nila. Inhibit nila ang enzyme, the HMG-CoA reductase, para, again, hindi siya si HMG-CoA hindi maging mevalonate and hindi siya mauwi as cholesterol. Okay? And I believe you are very much familiar with our statins. Okay? Statins lang yung tawag natin pero talagang name talaga nila HMG-CoA reductase inhibitors. So ito yung mga examples ng ating statins. Lovastatin, atorvastatin, fluvastatin, pravastatin, simvastatin, and rosuvastatin. Ito yung mga brand names nila ha. Now, if you're asked again, what's the mechanism of action? Mag-inhibit ng enzyme called HMG-CoA reductase. Okay? Para hindi maging cholesterol si HMG-CoA. Si HMG-CoA saan galing? Sa acetyl coenzyme A. Saan galing sa acetyl coenzyme A? Sa kinain mo. Either carbohydrates, fatty foods, or cholesterol-rich foods. Even proteins, when they break down, they become acetyl CoA. So kaya, yun yung sinabi ko, pag kumain ka ng marami sa gabi, marami kang source ng raw material for you to have a lot of cholesterol. So, tama talaga yan. Kumain ka ng marami sa umaga kasi nga marami tayong ginagawa, pero kumain tayo ng konti sa gabi. Ang problem sa atin, wala tayong appetite sa umaga, tapos lami kayo ikaon sa gabi. Which is baliktad, kaya tayo tumataba. Okay. So what are the effects, class, of administering these drugs to the patient? Ano ba mangyayari sa body? Siyempre, magre-reduce yung cholesterol synthesis. Okay? And mag-up-regulate yung mga LDL receptors on hepatocytes para ma-reduce ang production ng LDL. Remember, LDL is a bad cholesterol. So ganito, please take note. Bakit nasama dyan si hepatocytes? Sabi ko kanina, diba, si glucose, aside sa kinakain mo na carbohydrate, pwede ka rin magkaroon ng source of glucose galing sa liver. Kasi yung liver natin, Marami dyan, glycogen. Pag nag-breakdown yan, may glucose ka na naman ulit. Now, ganun din, class. Wait lang. Okay. Ganun din, class, ang sa cholesterol. Aside sa kinakain natin, yung liver natin is capable of producing our own cholesterol in the body. So, magiging times 2 na yon. Now, pag uminom ka ng statins, mai-inhibit yun both yung pagka-produce ng cholesterol galing sa kinain mo and yung pagka-produce ng cholesterol na galing sa liver. Okay? Yun talagang dalawa yung mai-inhibit. Kasi yung pagka-form ng cholesterol talagang dadaan siya doon sa activity ni HMG-CoA reductase. Now, yung yung mga statins natin, wala yung reaction nila or yung action nila on triglyceride, hindi ganun ka-significant. Okay? Remember, separate si cholesterol kay triglycerides ha. Si cholesterol talaga yon. Sterol talaga siya. Meron siyang si TPP nucleus. Yan yung hinahanap natin sa di ba? Sa mga sterol. Si triglycerides, lipids pa rin, pero fats and oils in the body. So, wala masyadong activity doon si statins. So, yung mga statins natin are our first line drug for atherosclerosis. Okay? Binibigay talaga yan sila for patients at risk or yung meron na talagang atherosclerosis and yung mga clinical sequelae ng ating atherosclerosis. Yung pag may atherosclerotic plaque ka na, pwede ka na magkakaroon ng ibang condition like yung acute coronary syndromes na part ng ating angina, arrhythmia, and even heart failure. Okay? Now, what's our problem? This one is a board exam question. Our problem with statins class, number 1 talaga yan is rhabdomyolysis. Ang problem dyan, this drug mismo class may side effect siya na ang magiging target niya yung skeletal muscle. It will trigger the breakdown of the skeletal muscles. Kaya may myopathy dyan, masakit yung muscles, and then mag-rhabdomyolysis na talaga pag nag-breakdown yung muscles kasi yung mga degradation product, mapupunta yun siya sa blood. Tapos, syempre kung nasa blood siya, mapupunta siya sa heart. And then, pag napunta siya sa heart, nagiging toxic kasi yun siya sa heart. So, it may cause heart failure. Or kung napunta siya sa kidneys, mahihirapan yung kidneys na mag-filter nun sa degradation product ng muscles. And pwede siya mag-lead into kidney failures. So, yan yung problem with statins. So, even if this is really given to the patient, most of the time nakikita natin ito sa community, pero we really have to monitor our patients also for a possible rhabdomyolysis. I read an article regarding the incidents in South Korea, yung Halloween party nila, but there was a crowd crush and some of them were actually injured kasi na apak-apakan sila doon, no? Pero maraming patient doon na nag-rhabdomyolysis. Kasi nga, di ba, na datugan na sila dito na ilahang example, ang ilahang tiil, na tamak-tamakan na dito. So, nakita ko yung picture, talagang bruised yung whole legs, gikan sa taas hangtod sa lapa-lapa, ng violet na siya. Akato siya, may na-diagnose na yung person na nakita ko sa article ng rhabdomyolysis. Namatay talaga yung mga muscles niya, no? And syempre kung namatay yun siya, nag-breakdown yun, and yung degradation product, yun yung magiging life-threatening for her kasi pwedeng maapektuhan yung heart and yung kidneys. Pero this one is on the drugs ha, kasi yung rhabdomyolysis can be caused by injury or by infection or by the drug pag may toxicity sa drug. So isa yung statins natin. So aside from myopathy and hepatic dysfunction. Now, board exam question, anong time of the day natin binibigay yung ating mga statins. Please take note of this kasi hindi lang sa board exam, even sa practice, kailangan alam nyo yan. Ganito, since ang ating cholesterol synthesis sa gabi siya nagte-take place, syempre sa gabi nyo din iinumin itong mga statins class. Kasi ano naman yung i-inhibit niya sa morning na wala namang cholesterol synthesis sa morning. So please take note of that. Kasi nung buhay po yung father ko, there was a time na I was the one na nagbantay sa kanya sa hospital, and then pumasok yung nurse. That was noon time. Tapos, kinausap niya ako, sabi niya, ibigay ko daw sa father ko. I was pharmacist that time na ha. Ibigay ko daw sa father ko, ipainom ko. So pagbasa ko, simvastatin. Ako dyan siyang giingnan. Ako siyang giingnan nga, ma'am, di ba sa gabi, maning siya ginahatag. Tapos, murag na natigilan siya. Hindi siya sure. So, mataan siya, sige lang ma'am, kay pangutanon daw niya ang doktor. Mato, nilakaw siya, balik siya sa station. And dito, after some time, nibalik siya. So, mato, ano siya nga, yes ma'am, sa gabi, EDI. Mato, ano ko nga, kani makalimot. Kaya kung sa community ni siya, kung wala ka nag-inform sa patient, yung pag-inom nila ng drug will be useless. We will not achieve the maximum optimal effect or optimum effect of the drug if pati yung time hindi tama. Pero take note class, wait lang ha. Itong atorvastatin and the rosuvastatin are long-acting statins. So ito lang silang dalawa yung permitted na pwede mo silang i-take sa morning kasi again, long-acting sila. Long-acting. Pero kasi yung case na na-experience ko, that was simvastatin, and simvastatin is a short-acting drug. So do not give that in the morning. You really have to give that at night. Okay, I hope that is clear. Do you have questions about our statins before we'll continue with our fibrates? Clarifications? Wala. Sure na. So the next one, we have the fibrates. So this is another group of drugs, drugs for hyperlipidemia. Examples of our fibrates are the fenofibrate and the gemfibrozil. I think the Lipway, that's the brand, Lipway SR is also fenofibrate, if I'm not mistaken. Okay, sige, brown out. Idagdag nyo na lang siya dito sa enumerated na mga brand names. Okay? Now, we have encountered this one a while ago in the discussion sa oral hypoglycemic agents. Kaya lang, PPAR gamma kasi yon. Our pioglitazones act on the PPAR gamma. Well, except for pioglitazone because it can also be an agonist sa PPAR alpha. Pero yung mga fibrates talaga natin, their action is on the specific ito, PPAR alpha. They are PPAR alpha agonists. Na-mention ko din kanina kasi itong mga PPAR receptors natin, both yun, glucose and lipid metabolism. So kung encounter natin sila sa oral hypoglycemic agent, may encounter din natin sila dito sa lipids natin. So kapag i-activate mo kasi ang receptor na to, the PPAR alpha, that will help in the metabolism of our lipids, especially this one, the lipoprotein lipase. So this is the enzyme that we need to metabolize our lipids. So kaya yung effect niya, kapag na-activate mo yung receptor, ma-activate mo din yung enzyme na ito. So parang sequel na siya, no? Tuloy-tuloy na siya na activity. Okay? So what will happen aside from na metabolize mo yung lipids mo kasi nga activated yung enzyme, magdi-decrease yung secretion of VLDL. So VLDL is, again, very low density lipoprotein. So kasama ito ni LDL na considered sila as not really a good cholesterol. So ito yung isa sa magde-deposit and magiging atherosclerotic plaque. And saan marirelease si VLDL doon sa liver natin. Okay? But another good thing about our fibrates is mag-increase yung HDL levels. Ano yung HDL? Good cholesterol, high density lipoprotein. Pag high density lipoprotein kasi mas marami yung protein kesa sa lipid. And paano siya naging good? Kasi ang trabaho niya maglinis. Like sa blood vessels natin, pag marami kang HDL plus, lilinisin niya yung blood vessels natin for extra cholesterol. So yung mga extra cholesterol na yan, kukunin yun ng HDL, dadalhin sa liver for metabolism. Okay? Nabaliktad kasi si LDL, kaya si LDL naging bad cholesterol kasi hindi siya naglilinis. Instead, siya yung dumadami. Example, in our blood vessels. And pag dumami siya doon, siya din yung nagiging atherosclerotic plaque. Okay, that is just to differentiate why the other one is called good and then the other one is called bad. Okay, so ang kailangan talaga natin in the body na mataas na level is CHDL. Okay? Lang, ha? Okay, so clinical applications of our fibrates. So pwede siya for hypertriglyceridemia. Ito yung condition wherein hindi yung cholesterol yung yung mataas. Ang mataas yung fats and oils in the body. Okay? Kapag i-check yung blood glucose, yung blood mismo ng patient, mataas yung triglyceride. So, remember, ma-activate yung lipoprotein lipase na mag-metabolize nitong fats and oils na ito. And it can also lower down HDL. Remember, magde-decrease yung secretion ng VLDL from the liver. VLDL kasi will eventually become LDL. Okay? Kaya pwede din naman. So, di ba si statins, wala silang activity talaga na significant sa triglyceride. So, ito kung ang problema mo triglyceride, ang binibigay, fibrates. Okay? Now, toxicities, nakabold dyan. Ito talaga yung kanyang, mostly ma-encounter natin sa patient, mild GI disturbances. Okay? Aside from the myopathy, it can still affect the muscles though. Most of our drugs for cholesterol may activity sa muscles. Kasi yung muscles natin kailangan naman ng source of energy yan. So pag pakialaman natin yan, ayun, kaya may myopathy dyan. And then hepatic dysfunction. But remember, papakialaman din natin yung liver nito para hindi siya mag-produce ng maraming cholesterol. And the gallstone formation. Merong mga ibang patients. Okay? Next, bile acid sequestrants. These are the drugs under the bile acid sequestrants: cholestyramine, cholestyramine, and cholesebalam. Mga brand names nila ito. Ano naman ang mechanism of action of this group of drugs? We have bind bile acids in gut and ito gut and excrete it in the feces. Okay? May end pa dyan na and excrete it in the feces class. So bile acids. Siyempre, nasa bile natin yan. And yung bile class is actually made up of cholesterol. So, kailangan natin si bile, no, para ma-digest natin yung kinakain natin na lipid or mga cholesterol or fat or oil-rich foods natin. Kailangan natin si bile dyan. Pero again, si bile mismo is made up of cholesterol. Now, ang ginagawa ng mga bile acid sequestrants natin, from the name sequestrants, magbabind sila dun sa bile natin. Again, magbabind sila sa bile natin. And pag nagbind ka sila doon sa bile, ang mangyayari sa bile, ma-excrete siya, masasama siya sa stool natin. Now, anong connection nun, ma'am, sa mataas na lipid or cholesterol level in the body? Ang mangyayari kasi, kapag na-excrete itong bile acid sa feces na ito, syempre kailangan mo pa rin ng bile. Yung body gagawa na naman ng bile. Now, saan galing yung gagawa gagawin niya na bile dun sa cholesterol. Sabi ko nga kanina, bile is made up of cholesterol. So yung cholesterol mo sa blood mo or sa other parts sa body, kukunin yon, dadalhin doon sa bile para sa liver, I mean, para magpo-produce ng bile acid na naman. So that's in that way, bababa yung cholesterol mo sa body. Kasi yung mga excess doon sa body mo gagamitin to make this one. Okay? Tapos kung constant kang umiinom ng bile acid sequestrant, so syempre parang maglilinis yung katawan mo. May excrete na naman yung nagawa ng bile acid. So maggagawa na naman siya ng panibago. So kukuha na naman siya ng cholesterol dyan sa blood mo, most likely sa blood. Okay? Yan yung connection niya sa na naging drug siya for hyperlipidemia. Okay? So again, yung cholesterol mabe-breakdown, gagawin siyang bile acid. Hindi na ma-reabsorb yung mga cholesterol, yung bile may excrete na. So definitely magbababa yung cholesterol overall in the body, and yung mga LDL receptors mag-upregulate, hindi na mag-produce ng maraming cholesterol. So ang ending talaga bababa yung LDL. So these drugs are actually for those person na mataas ang cholesterol. So wala pa rin itong activity in the hypertriglycerides or hypertriglyceridemia. Okay? So para talaga ito sa mga conditions na mataas ang cholesterol. Okay? So, ano example ng conditions na mataas ang LDL, the type 2A and type 2B hyperlipidemia. Okay? And aside from that, digitalis toxicity. Bakit nasali si digitalis dito, si digoxin? Kasi, di ba sequestrant sila? Aside sa na-sequester kasi nila yung bile, pwede din kasi silang mag-sequester ng digitalis. Didikit din sila sa digitalis, tapos may excrete yung digitalis. So kapag nasobrahan ang patient ng digoxin, for example, pwede natin siyang gamitin as antidote. Okay? And then aside from that, pruritus and type 2 diabetes mellitus. Sa type 2 diabetes mellitus, hindi masyadong known yung mechanism of action niya, but I have read that pwede siyang mag-decrease ng resistance to insulin. Though yung talagang explanation paano niya i-decrease yung resistance sa insulin, hindi pa nila tukoy. But a lot of clinical trials have already demonstrated na talagang effective si colesevelam to decrease the blood glucose level also. And si cholestyramine for pruritus, ganito kasi yun, kapag mataas ang cholesterol mo, ma-activate din kasi yung mga substances natin sa body na responsible for like allergic reactions like pruritus, inflammation, ganon. Kaya kasali din siya na parang associated siya na you will have like itchiness, mga rashes sa katawan mo kapag mataas din yung cholesterol. So kapag i-sequester natin, yan yung parang explanation why cholestyramine can be given for pruritus, but the pruritus should be associated with the increase in the cholesterol in the body. Okay? Now toxicity constipation, kasi yun naman talaga yung activity niya, i-sequester yung bile para ma-excrete siya sa feces. So yung kanyang mechanism of yung kanyang toxicity is most likely on the gastrointestinal tract. Siya. So the patient may experience constipation and bloating. And this may also interfere with the absorption of other drugs and vitamins kasi kasali din yun ma-sequester instead na paggamit mo pa sila sa body mo, sa effect nila, may excrete din sila kasali doon sa bile na sinequester ng mga bile acid sequestrants. And ito yung isa sa board exam sa questions, steatorrhea. Steatorrhea means oil or like oily substance like na makikita sa feces. So parang ang stool ng patient na ito ay parang oily or fatty, ganon. That's called steatorrhea. Pero this is contraindicated in hypertriglyceridemia. Wala kasi talaga siyang activity sa fats and oils, sa cholesterol lang. Okay? Questions? Malapit na tayo matapos. We have sterol absorption inhibitor. We only have one drug here, the ezetimibe. Ang kanyang brand name ay Zetcha. Ano naman ito? Black's sterol transporter. Ang tawag sa sterol transporter na yan is NPC1L1 in intestine brush border. So this one naman inhibits absorption of dietary and biliary cholesterol. Kung i-compare natin sila with the oral hypoglycemic drug, parang ano ito, carbose, parang alpha-glucosidase inhibitor. Di ba si alpha-glucosidase inhibitor inhibits the enzyme that will degrade the carbohydrates para hindi siya ma-absorb. This time, for our drugs for hyperlipidemia, ito na yon si ezetimibe, na yung sterol mismo, na yung cholesterol na galing sa kinain natin, hindi siya maa-absorb kasi i-inhibit natin yung transporter na magdadala sa cholesterol na kinain natin from the intestine to the blood. Okay, kasi pag umabot yan sa blood, ayun na, tataas na yung ating cholesterol in the body. Okay? So, again, this will inhibit reabsorption of cholesterol excreted in bile, and then sa food din natin, walang ma-absorb, walang ma-reabsorb. And magdi-decrease syempre yung cholesterol, no, yung LDL and phytosterols. So, phytosterols, remember, are the sterols found in the plants. So, hindi lang siya sa cholesterol na galing sa ibang foods like sa meat, pati yung phytosterol sa plant, hindi kasi natin siya maa-absorb talaga kasi nga inhibit yung transporter. So, kailan natin gagamitin si ezetimibe? Kapag may hypercholesterolemia, like tataas yung LDL ng ating patient. And yung sa mga persons experiencing phytosterolemia, yung pataas naman sa kanila, yung phytosterol na galing sa kinain nila na mga plants. Yung mga mga vegetarian natin, no? Hindi din sila kasi they cannot also get away with this one. Pero hindi kasi magkaiba yung cholesterol and phytosterol. Si cholesterol yung sa atin, sa human and sa mga animals. Yung sterol na nasa plant, phytosterol yan. And then it can also accumulate in the body. So ito yung ginagamit natin for phytosterolemia. Okay, toxicities, hindi naman kagaya ng ibang drugs like statins and fibrates and bile acid sequestrants na talagang makakaapekto sa liver. Ano lang naman, low naman, meron pa rin pero low incidence of hepatic dysfunction, but you still have the myositis here. So we're still talking about the muscles. Okay? Talaga yan yung target ng ating mga drugs. And lastly, we have the niacin. Remember, tara na, thiamine, riboflavin, niacin. Niacin is the vitamin B3. Other name for vitamin B3 is nicotinic acid. So vitamin B3 class is included sa list ng mga drugs natin for cholesterol. Now, paano si vitamin B3 maglinis sa katawan natin with the cholesterol? Actually, not cholesterol, it's the triglycerides. Okay? The strongly inhibits lipolysis in adipose tissues, thereby reducing production of free fatty acids which are used in triglyceride production. So, ganito kasi yun. Sa adipose tissues natin, for example, sa nawong daghan tag-adipose tissues, sa tiyanjo, daghan og adipose tissues. So, diba sa adipose tissues, that's where we store our fats. Now, kapag mag-lipolysis kasi class, lipolysis is breaking down of these fats, no, in our adipose tissues. Pag na-break down kasi si fats, magre-release yan siya ng fatty acids. Tapos pag si fatty acids na-release, pwede siyang gamitin to make more of the triglycerides, which is makikita siya sa blood. So kapag tinest yung blood ng patient, mataas yung triglyceride levels niya. And meron yan siya syempre mga corresponding effect in the body. So mga heart conditions pa rin, cardiovascular conditions, atherosclerosis, and so on. Pero magkaiba sila sa cholesterol ha. Pero ganun yun. Ang gagawin ng vitamin D3, hindi mababreakdown yung mga fats natin dito para walang fatty acids na pwedeng gamitin to produce a lot more of triglycerides. Yun yung kanyang activity talaga. And at the same time, it will also target the liver so that the liver will not produce more of cholesterol also. So dalawa talaga ito, triglycerides and cholesterol. VLDL is a cholesterol class. So kung titingnan natin ang effect, syempre, magde-decrease yung cholesterol, especially the lipoprotein A, the LDL, and at the same time, the triglycerides kasi walang available na fatty acids na gagamitin to produce them. And at the same time, meron siyang activity in the increase in the HDL. This one naman is our good cholesterol. So, pwedeng gamitin si niacin or vitamin B3 for familial hyperlipidemias and yung sa mga may severe hypercholesterolemias na talaga. Taas yung cholesterol, mataas yung triglyceride. Kung both na talaga ha, pag-check ng lipid profile, both talaga mataas, lipids and triglycerides. That's the time we use the niacin. Okay? Vitamin B3. Pero when it comes to the toxicities, we have here the flushing. Talagang mamumula, magdadilate ang blood vessels, mainit na feeling. Yun yung talagang effect ng vitamin B3. Pero ang treatment natin dyan to avoid the flushing is aspirin. Okay, please take note of that. But aside from that, you have the gastric irritation and then hepatic toxicity. Remember, target niya din yung liver para hindi mag-produce ng maraming cholesterol. And it may reduce glucose tolerance also and may cause hyperuricemia. But all in all, that's our drugs for our hyperlipidemia. Do you have questions or clarifications? It's already time before tayo mag-end. Wala. So again,